who may not be as familiar with our organization, we are the Wisconsin Cancer Collaborative, and we are a statewide coalition of 140 organizations working together to reduce the burden of cancer for everyone in Wisconsin. If you are not yet a member, we would love to have you join us. Membership is free, and you can do so at the link below. The agenda for today's call will be we will start with just a brief intro where I will go over the Wisconsin Cancer Plan section on reducing exposure to UV radiation. And then we will hear presentations by Dr. Zhu, Dr. Albertini, and Sherry Scott. And then at the end, we will have time for questions. And to kick off today's call, we're going to start by doing something new. We're going to start by asking everyone in the chat just to drop your favorite type of cheese. We're interested to see and just open up the conversation a little and get everyone warmed up for today's call. I can start. My favorite is a good Bella Vitano. So while people are dropping their favorite cheeses in the chat, I will start by talking about the Wisconsin Cancer Plan section on decreasing exposure to UV radiation. So this section is found within Chapter 2 of our risk reduction chapter, and it's Priority 5, and it's decreasing exposure to UV radiation. And so the Wisconsin Cancer Plan identifies a couple different strategies to help address this. And the first strategy A, is increasing opportunities for sun protection in outdoor settings. And action steps to help do this include increasing availability and use of things like shade structures and SPF 15 or higher in outdoor settings, especially in low-income communities, educating decision makers on evidence-based policies that increase availability and use of shade structures and SPF 15 or higher sunscreen in both public and private outdoor spaces. The second strategy that the Wisconsin Cancer Plan highlights is increasing awareness about skin cancer prevention. Action steps to help do this include training education professionals to reinforce skin protective behaviors for youth by modeling, demonstration, and role-playing. Other action steps include encouraging healthcare providers to educate patients about skin protective behaviors, also increasing targeted skin cancer education for outdoor workers, and also tailoring education and awareness activities for populations with darker complexions to normalize skin protective behaviors. And the third strategy is to decrease indoor tanning use. So ways you can help to do this include educating policymakers on evidence-based policies that reduce indoor tanning use, especially among youth, maintaining and following FDA regulations on indoor tanning use, reducing youth access to indoor tanning, developing and implementing public awareness campaigns to highlight the dangers of indoor tanning, and also decreasing the availability of indoor tanning in health and wellness facilities, such as fitness centers and spas. So those are some of the strategies and action steps the Wisconsin Cancer Plan identifies. And later on today, we will actually hear from a Wisconsin Cancer Collaborative member, Sherry Scott, who has helped to implement some of these in her community. But now it is my pleasure to introduce Dr. Gloria Zhu, who I believe is on the line now.
Yeah, I'm right here.
Awesome. So what I am going to do is read a quick bio, and then I'm going to give you control to advance your slides. So she earned her medical degree from the Sun Yat-sen University of Medical Sciences in China and completed her residency at the University of Chicago Hospitals and her Mohs Fellowship at the University of Wisconsin-Madison. She is the lead dermatologic surgeon in the treatment of thin melanoma as well as non-melanoma skin cancers. She represents the University of Wisconsin Carbone Cancer Center as a member of NMSC Guideline Committee of the National Comprehensive Cancer Network since 2016. She has published more than 30 articles on surgical and general dermatology in peer-reviewed medical journals and written multiple book chapters on dermatologic surgery and cutaneous oncology. She has also been invited as a speaker at multiple national meetings. So now I will give her control and you should be able to take it away.
All right, that's great. Let's see if my slides come up. Or...
So if you click forward, it should get you there.
Okay. Click forward. All right. Yes. Just forward on my. Oh yeah, got it. Thank you. That's perfect. Thank you very much. All right, I haven't done that. Okay, with somebody showing you my slide and I control that. That's new. So thanks for the opportunity to talk about melanoma tumor board and risk factors of melanoma. As the introduction says, I'm a Mohs surgeon who takes care of thin melanomas and non-melanoma skin cancers in my daily practice. I don't have any conflict of interest. Okay, next one. I think that's interesting. Maybe.
Try clicking forward again. It should.
Do I use my arrow on my left?
You can use either your arrow or the mouse.
It's not advancing for me actually when I use that.
Alex, why don't you take over the control?
That's fine.
Yeah, you go ahead, take over. That's fine. Go ahead, take over.
Okay.
Sorry about that. Okay. Yeah. So in the next 15 minutes or so, I'm going to briefly touch upon melanoma tumor burden and melanoma risk, melanoma incidence and risk factors, mainly focusing on UV rays. I will emphasize the correct use of sunscreens and other means of sun protection. I would also like to show some skin lesions that are concerning for melanoma to underscore the importance of early melanoma diagnosis. Next slide, please. So according to American Cancer Center, the estimated new cases for this year of melanoma, skin melanoma, a little over 106,000 cases. The male is slightly more than female, and estimated deaths for this year is a little over 7,000. Next slide, please. So as you can see, melanoma is the 5th most common malignancy among all malignancies. But when you look at the right side, estimated deaths, melanoma is not on the top 6 list, indicating that the early diagnosis of melanoma and appropriate treatment of melanoma might play a good, positive role in melanoma outcome. Next slide, please. If you break down to different states, California is way up there. Next slide. So if you look at Wisconsin, Wisconsin is kind of like right in the middle. We have 2,400 cases estimated, new cases this year, and 150 deaths. Next slide. So when we talk about melanoma, melanoma is a whole terminology, but it is composed of different subtypes of melanoma. As showing this nice article here, you can have oral melanoma, oral mucosa. This is nodular melanoma, like a thick dark bump. And this is a melanoma in the sun-exposed area called lenticular malignant melanoma. This one is the most common one. The 4th one is the most common one. It's called superficial spreading melanoma. And the last one is on the toe. It's called acrolentiginous melanoma. So what's fascinating about melanoma is that each different subtype of melanoma actually has its own specific molecular pathway that ultimately leads to cell proliferation and decreased differentiation apoptosis, and therefore the formation of melanoma cancers. And this pathway presents a lot of targets for drug intervention, which will be covered by Dr. Albertini later on. Next slide, please. So as I said, superficial spreading melanoma accounts for majority of melanoma, 60 to 70%. Let's move on to the next slide. Okay, when we talk about risk factors, and I'm going to borrow this slide from NCCN guideline, that's National Comprehensive Cancer Network. It updates guideline every year. Dr. Albertini presents our UW Cancer Center as a member of the NCCN melanoma guideline, and I represent in the non-melanoma skin cancer guideline. So as you can see, there are multiple risk factors like male sex, older age, phenotypic predisposition, mainly talking about your complexion, your fair skin, red hair, blue eyes, numerous atypical moles, and a medical conditions such as organ transplant, immunosuppression, and genetic disposition, such as genetic disorders and mutations. But what's important is next slide. We want to know if there's anything we can control, right? Strategically manage. That's the external environmental factors, mainly the UV rays, and that is both from the tanning bed use and natural sunlight. Next slide, please. So tanning beds, as we know, the UV rays is a known human carcinogen, and tanning beds are composed of multiple wavelengths of UV rays and typically carry more damage than natural sunlight. And it's one of the reasons that we start to see more melanoma incidents in young women. I'm glad to say that multiple states actually have laws to prohibit minors from using indoor tanning beds. However, it's still it's an ongoing battle, and we should try our best to educate public better. Next slide, please. So I'm going to kind of do a little overview of UV rays. UV rays based on different wavelengths, it's divided into 3 different components, A, B, and C. The UVC is really not relevant to us because it's reflected back to the sky. UVB and UVA, UVB is shorter, as you can see in this cartoon. It gets to your epidermis, which is the most superficial layer of your skin. It doesn't really penetrate more than epidermis. Versus UVA, it's longer wavelength, it penetrates deeper and go all the way to your dermis. And they both actually carry damage to your DNA, but they show a little bit difference as showing next slide. Next slide. And so for UVB, it causes immediate burning sensation. It is usually blocked by window glasses. It carries high energy that can cause direct cellular DNA damage. UVA, that longer wavelength, it penetrates deeper and causes delayed tanning. Penetrates glass window glasses. It has low energy, but it has longer term cellular DNA damage. Both UV rays actually responsible for at least the risk factors for skin cancers, aging of the skin, and immunosuppression. Next slide, please. So it's always fun to do a make a guess type of questions. Like I'm going to ask you guys to think about. I'll give you an answer right away because I can already see you guys and get an audio response. So, but think about it. What percentage of UV rays reaching Earth are UVA? Next slide. It's actually 90%. So most of them is the long wavelength that penetrate the window, right? So that's important to know. And fourth, true or false? People might say, I only need to wear sunscreen in the summertime, or I don't need to wear sunscreen in the cloudy days. Is that true or not true? Let's move on. So how much percentage of UV rays actually penetrate clouds? And think about the surface that will reflect UV rays, sand, water, and snow. Which one actually reflects more? So next slide. So actually 80% of UV rays penetrate clouds. They answer your question. In cloudy days, you still have to be careful with the sun exposure. There's no sun, but UV exposure. And the snow actually reflects most of the sun rays. So that's why when you go out skiing in a sunny winter day, you still have to do sun protection. Okay, and the risk of indoors, as I mentioned earlier, carries more damage to the DNA damage to the skin. Up to how many times more UVA radiation is shown in indoor tanning? It's 15 times more, so it's pretty significant. Next slide, please. So just a quick slide to show the proper use of proper selection of sunscreen. We usually recommend that. It's pretty simple. Tell patient you want to do SPF 30 or higher, and you want a broad spectrum, which covers both UVA and UVB. And now, a few years ago, that's mandatory, FDA mandatory, that all the sunscreen bottles or tubes, they have to put broad spectrum or not on their bottle. Years ago, it was not specifically said. You have to read your little prints, look at the ingredients. Now you don't have to. It's always there. And waterproof. One more thing about waterproof or water resistant, there is nothing waterproof. So, for athletes, you always tell them that you have to reapply because it only lasts for like 40, 80 minutes. And then you have to reapply. One common mistake people use is they don't use enough. It's not thick enough. So 1 ounce of sunscreen usually covers an average people like sun exposed skin. You need 1 ounce, a shot glass. And I don't think a lot of people will use that many, so that's a common mistake. Next slide, please. So true or false again, sunscreen SPF 30, we said that's, higher or SPF 30, that's good enough. So if you say SPF 30 is twice as good as SPF 15, is that correct? If I say I want to look for SPF 100, and that probably will give me 100% protection, is that true or false? Both are false. And I'm not going to get into details, but just to say that SPF 30 actually block about 97% sun rays, 15 block 93. So it's not a doubling. If you go up higher than 30, you got marginal benefit. And if you look at SPF 100, it'll give you 99% protection from sun rays, so nothing's 100% in sunscreen use. Okay, next slide, please. So this is our website saying that our American Academy of Dermatology, our official society, actually updates detailed guidelines for public use on sunscreen. So sunscreen frequent asked questions by our AAD. This is a very good resource for people who want to dig more into details. Okay, next slide, please. So of course, other means of sun protection is very important. You want to recommend 6 shades, a UV protection clothing called a UPF. We typically say 50 or higher. You want to do long sleeves and pants and wide brim hat, sunglasses. And some of the UV protection clothing nowadays are actually usually pretty user friendly, and you can feel like your skin can still breathe underneath long sleeve. Pretty good. And you want to avoid sun at the middle of the day, right? Between 10 a.m. and 2 p.m. Go in early morning or later evening, and make sure you get enough drink, right? To prevent getting overheated. Next slide, please. I want to plug one quick slide into this presentation about vitamin D, because we have patients ask us, like, do I have to get sun exposure to get good source of vitamin D? And our official guideline says that the vitamin D from oral supplement is just as good as vitamin D you got from sun exposure. So here's a recommendation for different age groups, and then you can look into details later. Next slide, please. So in the next few minutes, I want to say that early diagnosis of melanoma is super important. Look at this next slide. So look at the diagram. It shows survival, years of survival based on different depth of melanoma or early versus late melanoma. So thin melanoma, less than 1 millimeter, you can see the curve is pretty flat, meaning that patients survive pretty nicely. But if it's thick melanoma, this curve drop, patient die easily. Next slide. Next slide. Typically, it says a 5-year survival rate. Estimated localized melanoma, early melanoma, there's no difference between melanoma patients and normal controlled population. If you have a regional lymph node mets, survival rate drop to 2/3, and distant mets, drop to 1/3. Next, please. So you want to avoid cases like that. This is a patient I shared with Dr. Optini years ago. If you have this much melanoma, that's too late. Let's look at next slide. So our society teaches public to look at ABCDE rules, and then it's just a good guideline. It's not absolutely true, but it's a good guideline. A is symmetrical looking, B is a border irregularity, C is different color. Diameter says usually it's bigger than 6 millimeter. But what's most important is evolving. If a mole started to change like that, even though it's small, we have to take attention, right? We have to pay attention and take biopsy. And next slide, please. And I'm going to show you just in a few real patients, like this is a flat, but you can see that there's different shades of color. A border is irregular. That's melanoma in situ. Next slide. And this is two shades of color, brown and pink, with a little bit irregular border. That's melanoma in situ. Next one. And this is actually superficial spreading, has a little bit depth already. You can see there is a little palpable area, a little pink and brown. Next slide, please. And then we did a excisional biopsy for diagnosis. Okay. Next one. And this is another superficial spreading. You can appreciate a little bit of papula, a little bit elevation, and not totally flat. Next one. And sometimes it's hard to tell melanoma from other mimickers. Like for example, if you look at these two, they look pretty similar. Next slide. But one of them is hemangioma. Next one. And this is melanoma breast depth already over 1 millimeter. Next slide, please. Another example here that you look pretty dark, pretty irregular. Next slide. And this, I'm sorry, I actually go back to this slide. I was just going to say that the ear one is actually called pigmented seborrheic keratosis. That's totally benign. It's a benign keratosis. And this right lateral neck one, this one is actually melanoma in situ. Okay, next slide. And sometimes you can have a long-term mole that looks a little irregular and you're not worried. It's totally legitimate to get it excised and test. And this one, unfortunately, it's actually not a melanoma. Good. Next one. And sometimes the pigmented basal cell cancer could mimic melanoma, but they have a little bit shiny surface, kind of translucent, shiny, we call pearly surface. Next slide. I'm going to finish my talk with this cautionary tale case. This is a patient also I share with Dr. Albertini with history melanoma, the big scar right here on the upper back. And one day he showed up in Dr. Albertini's clinic. Next slide. Dr. Albertini called me and said, hey, this patient had a little lump underneath the skin. It's when you look at the slide, you have nothing to see, right? It's just my drawing because there's nothing obvious, and you can palpate, and there's little lump right there. Next slide. And we did a little excisional exploratory excision. So my fellow helped me that day look at say, oh, maybe I'm lipoma because all this fatty tissue coming out, protruding. Fatty tissue could be lipoma, which is a fatty tumor benign. I said dig a little bit deeper. So we got a little bit deeper. Next slide, and you can see a little bit of darker color. Okay. Next slide. So guess what? It is a cutaneous mat of melanoma. If you look at next slide and we take the whole thing out, this looks like this. So in other words, for patients with a history of melanoma, and if you have a sub-Q, we call sub-Q like a deeper bump, we really have to take a good biopsy, deeper biopsy to make sure that we don't miss that kind of thing. Okay, so I don't think I have time for questions, because I think Dr. Aptini is supposed to talk right away, but any questions, feel free to email me. Okay, thank you.
Thank you so much. That was a wonderful presentation, and we'll save some time for Q&A at the end if you are able to stick around. So I will now transition and introduce Dr. Mark Albertini. So Dr. Mark Albertini is a professor of medicine at the University of Wisconsin. He is a nationally known melanoma researcher who has led treatment efforts for patients with metastatic melanoma at the University of Wisconsin Carbone Cancer Center since he joined the faculty in 1993. Dr. Albertini established the UW Carbone Cancer Center Comprehensive Melanoma Clinic in September 1994 and is the leader of the UW Carbone Cancer Center Melanoma Disease Orientated Team. With that, I am going to give him remote control and hopefully it works better this time.
Well, thank you so much for the very kind introduction. Actually, it looks like a younger picture of myself. That's fine too. Thank you. And thank you also for the invitation to speak today. And the title of my talk is something very dear to my heart, Treatment Advances for Melanoma Patients. This is my disclosure slide, and basically I have no conflict of interest related to this talk. And my objectives are twofold. The first is to identify practice-changing insights for treating patients with metastatic melanoma. And the second is to appreciate the potential of immune system interventions to improve survival for patients with metastatic melanoma. I'll start with a couple key facts. The first, as eloquently demonstrated by Dr. Shu, early melanoma is curable. So again, the essential public health message is early recognition, early detection, early presentation for care, and surgical management in the large number of patients will then be cured. The second fact is that melanoma, if it spreads to so-called distant sites, then called metastatic melanoma, is quite serious and can result in death. We have new treatments that are importantly giving hope and also improving outcome in a very real, tangible way that I'll describe for you for many patients with metastatic melanoma. So this is my lecture outline. I'll begin in the Dark Ages. I'll transition to the Age of Enlightenment, and I'll conclude with my vision for a better tomorrow. So the Dark Ages, metaphorically speaking, for melanoma, refers to that period of time before the year 2011. We had painfully few treatments, and even fewer treatments that would temporarily work. Median age was around 50, median survival around 6 to 10 months, 5-year survival estimate less than 5%. The one sentence summary: metastatic melanoma is a bad disease. This survival curve shows and emphasizes the point that I was making, and this is from Dr. Balch back in 2001, so again, back in the Dark Ages. Stage 1, so-called early melanoma, when recognized, detected, managed early, the vast majority of patients can be cured. In contrast, stage 4 melanoma, that being metastatic melanoma, you see the very steep drop off in terms of percent survival. Median survival less than a year, long-term survival very uncommon. And that's what we really had for many, many, many years. Enough of the Dark Ages. And I'll transition to the Age of Enlightenment. And what really allowed for this to happen were laboratory insights that have really improved outcomes for patients with metastatic melanoma. And I hope at the end of this lecture, you'll appreciate kind of my passion and interest in the laboratory really helping us identify solutions for our patients with advanced cancers, in this situation, advanced melanoma. So the first laboratory insight were that some melanomas contain targets for therapy. The important point to emphasize is that these targets were targets in the cancer cell, essential in controlling the tumor cell growth. So again, some melanomas had these targets. There were things that could be identified in the melanoma that was responsible for the melanoma growing. This was important because it informed and stimulated development of so-called targeted therapies. These are treatments identified against the target that can interfere with what makes the melanoma cell grow. And this was shown both with very preliminary preclinical studies and then additional preclinical studies and finally clinical trials, that in patients with the appropriate target, these targeted therapies could cause tremendous tumor regressions, sometimes quickly, even within days, and sometimes even cause bulky tumors to disappear. One of the challenges became quickly apparent, and as one might predict, these targeted therapies can only work if the melanoma has the target. The specific target that's been exploited to the greatest extent is a so-called BRAF mutation, and about 40% of advanced cutaneous melanomas will have this mutation. If the target's not there, obviously the treatment cannot work. So this spurred a whole bunch of drug development, and there are many drugs, so-called BRAF kinase inhibitors, MEK inhibitors, and really what's commonly used now is the combination of the two of those. And there are several pairs that are approved and are showing benefit for many, many patients in the clinic. That's the good news. The not as good news, I mentioned one part of it, and that's that many patients don't have the specific target. The other piece of the bad news is that the targeted therapies work for a while. The tumor cells almost uniformly develop resistance to targeted therapy within about a year. So I'll use a baseball game analogy here. The goal when you're up at the plate is to score a run. The targeted therapies help get you onto first base. Again, it can cause important regression, important symptom benefit, important extension of life, and for occasional patients can last for a couple of years. But for most patients, after about 10 or 12 months, they lose their effectiveness. I'll now describe the laboratory insight number 2, and that's that T cells are specific immune effector cells, a subset of our white cells called T cells, can recognize melanoma as foreign. And as shown in this cartoon drafted by Cindy Zuliger, a scientist in my lab, the T cells, our body's infection fighters and cancer fighters, recognize the melanoma cell by their very exquisite T cell receptor. It can recognize foreignness, here called antigen, presented on the surface of the cell, and then they get secondary signals that can amplify and activate the T cell to attack and kill and eradicate the melanoma cell. This was incredibly important as a foundational observation because it opened up opportunities to use the immune system, the patient's own cells, the patient's own defenses to fight against the melanoma. One problem was quickly identified, and that's that the melanoma reactive T cells in patients with melanoma were in fact a minority of the cells. And we were dealing with a numbers game. There weren't enough of these melanoma fighting T cells to effectively attack and eradicate the tumor. What was shown is that if you had more of these melanoma fighting immune cells, more of these melanoma fighting T cells, you could in fact cause tumor reduction, tumor eradication. And this solution, this problem, was identifying the so-called co-inhibitory molecules on the T cell that could leave them activated. The class of treatments were so-called immune checkpoint blockade. And that's the third laboratory insight I'd like to emphasize, and that's so-called immune checkpoint blockade. The T cells in their typical job in our bodies work to clear infection, also to fight other foreignness such as cancers. In the course of doing their job, they get turned on, they do whatever they think they should be doing, and then get turned back off again. What these immune checkpoint inhibitors do is disable the off switch. They keep the T cell turned on. They let the T cell continue to do its job and inhibit it from turning itself back off again. I'll use a car analogy here. It's like taking your car and cutting the brakes, leaving that car turned on. To extend this analogy, imagine you're a car, you're a T cell. You're sitting on top of a hill, and it's a parked car, and it's pointing down the hill. To effectively eradicate the cancer, you need to get down the hill past the stop sign. And what these immune checkpoint inhibitors do is cut the brakes, allowing the car, your T cell, to get past the stop sign to eradicate the cancer and hopefully clear all the available cancer. One problem became quickly apparent, and that's that the collateral damage can also occur. This is referred to as immune-related adverse events. And for those of you familiar with Lombard Street in San Francisco, not all hills are straight. And these immune cells, once activated, they basically cut the brakes on all the T cells. So both the ones we want to have activated that can go ahead and hopefully clear the cancer, but also other T cells that can fight against the body's normal self and cause dermatitis or rash, colitis or diarrhea, pneumonitis or cough, shortness of breath, etc. So understanding this balance and trying to identify strategies to manage these side effects has also been a nice area of development where we made a lot of progress. And this whole topic of immune checkpoint blockade was one of the major reasons why in 2013, Science magazine deemed cancer immunotherapy the breakthrough of the year. This also led to the approval by the FDA of many immune checkpoint inhibitors. They work by different mechanisms, anti-CTLA4, anti-PD1, and the two of those together, anti-CTLA4 plus anti-PD1, are even more effective. They can also cause more side effects, but in patients with advanced melanoma, can cause regression, perhaps half of the patients, and durable regression, potentially even curing patients with metastatic melanoma in perhaps 30 to 40% of patients. This huge advance really inspired me to write this commentary for the Journal of Immunotherapy of Cancer a few years ago, where I deemed to kind of continue to use the metaphor of the age of enlightenment in melanoma immunotherapy. And again, commented back on the dark ages where we had painfully few treatments that would work, and currently have many more treatments that are helping many patients, and in fact, curing some patients with advanced metastatic disease. I'll now conclude with my vision for a better tomorrow. And shown here is a pre-pandemic roadmap for a bike ride with several of my kids between Milwaukee and up in Door County. And that, while that informed our bikes, we've got roadmaps now that inform our treatments in the clinic. And the roadmap is crystal clear. Transformative insights in the lab will continue to guide progress in the clinic. Again, we've gone from being able to do painfully nothing to now helping many patients, perhaps curing some patients, but not enough. I gave you the numbers, and more than half of the patients still need additional progress. So what are we doing? At our cancer center, actually my lab is involved in two different endeavors. One is working with colleagues in our School of Veterinary Medicine to help pet dogs with melanoma. Again, these are not dogs that we give melanoma. These are our pets that also spontaneously get melanomas, primarily in the mucosal areas, such as in the mouth. Those dogs need better treatments, and we need models to help inform our treatments in patients. So we're doing some studies in pet dogs to hopefully help our pets, and perhaps more importantly, in my opinion, also help our patients. Secondly, to develop new strategies to activate these anti-melanoma T cells to get more of these melanoma fighting T cells that can be amplified with immune checkpoint blockade. One of the approaches we're using is a so-called immunocytokine. Again, I won't go through too many details, but it's a so-called combined molecule, part of which is an antibody that can bind to cells that express the certain marker. It's called GD2. On the surface of melanomas. And the other part is IL-2, which can activate immune effector cells. So it really helps target these immune effector cells to the site of the tumor and helps activate the T cells in the tumor. We've got a study going on in pet dogs where we're using this. Again, these are pets who have melanoma. They got even fewer treatments than people do. And we're proceeding with a so-called intratumoral approach to identify strategies and sequencing that may be beneficial. And we're also monitoring these dogs quite closely. In parallel, we have a study in patients with advanced melanoma using what's called intratumoral immunocytokine combined with radiation of the tumor site, combined with immune checkpoint blockade to hopefully both activate an initial immune response and then make it more potent with the immune checkpoint blockade. My collaborators, Dr. Zach Morris in radiation oncology co-chair, laboratory co-chair, Dr. Jackie Hank, pathology co-chair, Dr. Eric Ranheim. And this is supported by an NCI grant. The PI for the grant is my good friend and colleague, Dr. Paul Sondel. And our first patient was treated back in February of 2020. So this is my last data slide. This again is a survival curve. And what you see in the purple is what we accomplished back in the dark ages with essentially no patients or very few patients living long-term. Our targeted therapy is improving survival, but unfortunately for most patients, it only works for a certain length of time. With our current immune checkpoint blockade, some patients are living, we're helping many patients, and some patients are living long-term and some likely being cured. And where I hope to go with some of these combined approaches is making that even better and truly helping our patients with advanced melanoma. So I'd like to acknowledge the many individuals in our team I feel privileged to work with and really call out Dr. Cindy Zuliger, an incredibly skillful scientist in my lab who also is great at PowerPoint presentations and really helped with a lot of these slides. My colleagues in the Cancer Center, both in the clinic and our clinical research team. And also funding both the VA Merit Grant that is supporting our study in pet canines, our clinical grant, foundational support from the Cancer Center, and philanthropy. And philanthropy has really been essential for some of the higher risk, higher yield studies that have formed the foundation for a lot of what we're doing. My final point is, well, meaningful progress has happened, and hopefully I've convinced you of that. Much more work still needs to be accomplished for patients with metastatic melanoma. Thank you. So after the last talk at the end, no questions.
Well, it is my pleasure now to introduce not doctor, but Sherry Scott, who has her master's degree in public health from the Minnesota School of Public Health. She included that nice little music in there for us before she starts her presentation. So before she dives in, I'm just going to read a quick bio for her and then let Sherry take it away. So like I said, Sherry Scott has her master's degree from the University of Minnesota School of Public Health and has worked as a community-based public health and evaluation consultant since 1999. Her partnerships have included tribal nations in Minnesota, national groups such as the CDC, state-based groups such as the North Carolina Tobacco Control Program, historically Black colleges, the Indigenous Peoples Task Force, and foundations such as Clearway, Minnesota, and the Center for Prevention at Blue Cross Blue Shield of Minnesota. Sherry has been an evaluation partner with the Wisconsin Cancer Collaborative for 15 years. She is currently working with her hometown rural community of Richland County on prevention campaigns, and today we'll be sharing information as a board member of the local cancer group, the Greater Richland Area Cancer Elimination, known as GRACE. Take it away, Sherry.
Great, thank you, Alex. And good morning, everyone. And yes, it has been a long, cold, lonely winter, as George Harrison sings. And I think that we're going to see people out in droves this summer because of that, because of the COVID winter that we've just been through. And, you know, it's already happening here in where I'm calling from in rural Richland County, which is the homeland of the Ho-Chunk people, the people of the sacred voice. And before I begin, I'd just like to acknowledge and thank the Ho-Chunk for the care and protection of this beautiful area where I'm at in the Driftless region of Wisconsin, and pledge to support the efforts of the Ho-Chunk Nation. So today I'm going to share some of the efforts of the community-based organization, which is the Greater Richland Area Cancer Elimination, or GRACE, I'm going to call it from now on. So GRACE has a mission to support people living with cancer in Richland and surrounding communities. And their main activity is an annual walk to raise funds. And as you can see on the slide here, it's called the Walk with Grace. And I'm just gonna, it's raised over $200,000, almost $200,000 or more every year since it began in 2004, which has added up to almost 4 million total raised since its inception. And for those of you on this call, I think it's particularly good to point out that 36% is dedicated to go to support research. And that has included basically 2 organizations that have been supported through all these years, and that's the UW Carbone Cancer Center, as well as Gunderson. Next slide. So the vision for GRACE is to support cancer patients above all. They give each year, they have 3 possible years worth of support. And that's to go for the patient's needs. They don't have a financial, any financial requirements or applications. It's simply a diagnosis of cancer. And they provide funding for research, as I mentioned before, and to the medical community. But the other thing that they do on the vision statement, or we do, is provide funding on prevention. Next slide. The issue with this has been they haven't really known what to do about prevention. And so originally, for most of the time, most of the years, there's been 5% that's been given to prevention. But since that wasn't being used, it has gone down to 0.05% of the budget. So they recognized this and reached out to some new board members, which I was included. And so I've just been working with them for a year. And one of the first things I did was join the Wisconsin Cancer Collaborative for GRACE. And I'm sharing all of the webinars and all of the great information that's available through the Cancer Council. And one of the only things that was on the radar for GRACE was sun safety. Next slide, please. So since 2012, they have been doing a screening event for skin cancer, and retired physician from Gunderson came, and as you can see here, 313 folks were screened by the physician, and they were able to find some precancerous conditions. So that's been a really great thing that they've done for prevention. But this year we were able to step it up and think about some additional ways to do that. And so next slide, please. We were able to collaborate with the new aquatic center, and it was just sort of a really good opportunity for us to do basically a strategy A and strategy B of the risk of the cancer plan to increase awareness of increase opportunities for sun protection. And so we purchased sunbrellas. They were pretty expensive, $3,000 each, but we were able to purchase 3 of those with the funds that were there. And then we also did the strategy B, which is education and awareness about skin cancer prevention. We have signs up all over. We include sunscreen, baskets of sunscreen, and yeah, you can go to the next slide. And I think that the great thing about that is that we were able to take an opportunity that was there. And this coming year, we're also going to do 8 table umbrellas. And it's really not a huge amount of money. It's going to be $4,000 to have 8 table umbrellas. And what I like to point out is that you know, we're meeting this community need. We're doing a collaboration, thinking about, you know, what wouldn't happen if we weren't able to provide this funding, but also the opportunity to do some things that are environmental changes, like the sunbrellas. You know, they don't require the family to do anything but sit under that umbrella to be protected. So that's you know, a great skin cancer prevention activity, and you know, also including those really simple messaging all around. We have posters on lifeguard chairs when you come into the aquatic center, where we just kind of really try to keep encouraging people about the, you know, the really easy things they can do for sun protection, especially when they're talking about, you know, their family, their kids. So the third thing I did want to mention, though, this is I've been having a really hard time finding educational materials in Spanish. And as we all know, equity requires extra work and resources. So if anyone has any of those available, I would love to put it in the chat for me, because what we want to do is to make sure to have the same information available in Spanish, because we do have a growing Latinx population in our community. So we're probably going to do some translation of those signs, but you know, some of the really wonderful materials that are available, it'd be great to have them in Spanish. And I know that I've spoken with some WCC folks, and they're willing to look at including some new resources. So that's it for me today. If you have any questions, let me know, or any suggestions, please drop it in the chat. Thanks.
Thank you so much, Sherry. That was a really great presentation. It's exciting to see our cancer plan in action in the community. So it's always fun to see examples like that. But now we will open up our Q&A section, and I will hand it off to Beth Brenner, our partnership manager, to facilitate the conversation.
Great, thank you, Alex. And thank you to all the presenters today. What wonderful information. And Sherry, you got a shout out on your love the music. So I think there's going to be more than just me. I told Sherry, I'm like, I am so going to figure out how to do that for a presentation. That is such a fun way to do it. So if you have any questions, please feel free to put them in the chat for any of our speakers or comments to share. Sherry, you can see Carrie from our team is saying, thank you for mentioning the importance of the equity in our public awareness materials. And we are hoping to have sun safety materials translated into Spanish. So if there are resources out there, please let us know. But it sounds like we are also willing to be an active partner in making sure those materials are available.
Thanks.
Yeah, and I'd like to give a shout out too. I think impressive progress and a very important mission. And I think as emphasized and hopefully clear from the first 2 scientific presentations, you know, I think the awareness, the prevention, the early recognition are clearly key messages. And as much as we made progress, and we'll continue to work our hardest to make more progress with advanced disease, the single best thing that can happen is prevent it. Next best is to pick it up early. And I think your efforts to get this in the community are tremendous. So I applaud those. Thank you.
Yes, I agree, Sherry, right? As parents, we're trying so hard to show our children the right way to wear sunscreen and to stay, but when it's in the community and you can see it and it's not just mom, that really helps share the message with the young people, which we know is a very critical point in time in life in order to embrace the active use of sunscreen and being sun aware. So open to questions if there's any in the chat, or you can also feel free if you'd just like to come off mute. Everybody should be able to do that as well if there's any questions. Well, I will ask one. I was waiting to see if there was anybody else, but as I mentioned, as a parent, what age do you see the need to be cautious on moles, right? So if you're seeing something, having a young person with a mole, at what point is there an age point where anything that's suspicious we really should be concerned about? Or as we saw the slides today, really what we're looking for. But, I always kind of think, is there a point that we should be really actively looking and seeking out medical attention or evaluation on something?
That's a tremendous question. And Dr. Shu is actually kind of in the midst of her clinic as well. So she could certainly answer every part if she gets back, but I'll give you my perspective in kind of two parts. And I've certainly cared for some individuals, even in their adolescent years, who've had advanced melanoma and melanoma diagnoses. Clearly, this is more common the older you get, and not even as cancers go, perhaps relatively less than some, but we're looking at majority of folks, it's more common, say, in the 50s and 60s, but a lot of folks, some in the teens, 20s, 30s. Had a young woman just last week who unfortunately now has a lymph node positive melanoma and is in the second trimester of pregnancy. So again, many challenging situations can arise. So I think to answer your question, while it's less common in younger individuals, it can still happen. And I think the short answer is, if there's an unusual mole, to have a low threshold, to have the primary care provider take a look. Early recognition, detection, management can cure the vast majority of these. The second piece is there's a lag time between the sun exposure and developing some of these cancers. So I think the message is both to identify those that look suspicious at younger ages, but also to prevent the blistering sunburns, the skin damage. And when it occurs actually in late adolescence, that's been pulled out as one of the higher risk time periods for those sun damage events to even occur. And while they might not manifest as the cancer until 20 years later, the event is actually occurring then. So I think if there's a mole you're concerned about, have your primary care provider take a look at it, is my answer.
Yeah, that's great information, because that's what we hear, right? Is people think it's older age, but knowing people that have been diagnosed in their 20s, that we really need young people to be aware that it can occur at any time. And for you, that statement on that like late adolescence and those not getting that blistering sunburn, I mean, that's the age, right, that we're starting to suntan and be out in the sun more without mom putting our sunscreen on. So those are really important messages for young people.
Excellent point. And I have patients in my clinic all the way from late teenage years to their 90s. So again, you can really see this through the spectrum of your life. But I think if there's a mole that's concerning, I would strongly recommend having it looked at, especially again in situations where there might be other predisposing factors, such as family history, et cetera. But regardless, if there's a concerning lesion, I would not just ignore it. I would strongly recommend having it looked at.
So we do have a question that's asked, do you think that a quick scan during an annual exam by a family provider is enough, or should it be a specialty visit? And then if it is a specialty visit, how often?
Yeah, so I think for the majority of patients, I think a skin exam, if incorporated into a usual annual checkup, would be reasonable and sufficient. I think if people have multiple pigmented nevi, dysplastic nevus syndrome, personal history of melanoma, other risk factors, I think those would also need and benefit from having a specialist such as a dermatologist. I think the low threshold to then push on to the specialist. I think we're also dealing with a resource issue where we really only have so many dermatologists. They're tremendously valuable and really, I think, are a key part in this. But I think trying to both educate and include our primary care providers as part of this mission will increase the healthcare professionals who are involved. And finally, I'd also want to add just the self-checking as well. And if people see something that looks suspicious, to have a low threshold to bring that forward.
That's helpful information too, as a cancer collaborative that's working with healthcare systems and, organizations in the community that are sharing message with providers, that we really work with those family practice as well providers and giving them the information on what to look for and how to educate, and keeping them in the loop of this educational piece to share with families is an important piece.
They're a key part of our team.
Mhm. Dr. Albertini, we have a question about the sun exposure, and is it cumulative over a lifetime, or is it, as you mentioned, the possibility that just that exposure in a certain time in life that increase your risk?
Yeah, so what's been really pulled out are like 3 or more blistering sunburns, and the highest risk time kind of in late adolescence, but it's really an ongoing factor. So I think it's really not a one-hit type process. So it's kind of hard to know when in that progression that is sufficient to trigger it. So again, I think clearly getting out, doing fun things, and even my patients with personal histories of melanoma, I'm suggesting they get out, they do their canoeing, their kayaking, their tennis, their jogging, they're playing with the kids. Again, as Dr. Shu pointed out, go out earlier in the morning when you can, below 10 a.m., go out later in the afternoon, wear sunscreen, SPF, we recommend 30 or higher, use sun protective behaviors. And with all that incorporated, one can enjoy the many positive things of being outside, but try to mitigate or decrease the risk in terms of the sun exposure.
Dr. Albertini, people also talk about those with fair skin are the ones most at risk. Again, do you see that in your patients? It's not just those with fair skin? I would assume that there's probably maybe just remind us all on that, because I think that's an important piece to share in communities too.
Excellent point. And it's not just those individuals. And I've had individuals of various different ethnicities with darker skin who also can get melanoma, but fair skin, light complected, tend to burn more frequently than tan. Red hair, blue eyes, there's a phenotype that basically are people who don't tend to repair sun damage as well as others. So they're at a higher risk. So that is actually called out as one of the potential risk factors. And there are more patients with those characteristics, albeit not having fair skin does not immune you from melanoma. And I should also say melanomas also occur in sites that don't even see the sun, so to speak. So if you have an unusual mole someplace where it's never gotten the light of day, so to speak, but looks unusual, to certainly bring that forward and have that looked at as well.
Great. Thank you, Dr. Albertini. And thank you, Sherry. We have a couple of people that have just commented. Thank you so much for your information today. Great webinar. Allison on our team shared that there's a new melanoma dashboard. So just so people can check that out too. And Tina, I'll turn it over to you. Or I'm sorry, Alex.
Yes, before we close out today, I wanted to highlight just a couple of resources that we have, including that melanoma dashboard that Allison posted in the chat. But first, we do have a sun safety social media toolkit on our website that you can find at the link below. You can use these to educate your social media followers on safe sun practices. We also have a melanoma infographic that you can download. And this is a great, easy to understand tool that you can use to help educate. And then finally, here is that link to the melanoma dashboard that was mentioned before. This provides a range of data on different states and local communities even. So it's a great tool to check out. And then our June networking webinar's topic is yet to be determined. So stay tuned for updates on that. And if you wouldn't mind sticking around to take a quick poll on today's webinar, it would be greatly appreciated. It should be popping up on your screen now. This webinar was recorded today, so we will make sure to send out the recording to you all and also the slides either later today or tomorrow. So thank you again for attending. And after you take our poll, feel free to log out and enjoy the rest of your day.